You know, when an older loved one has to face major surgery, especially with cancer involved, well, it brings just a huge amount of anxiety, doesn't it?
Oh, absolutely. It's completely understandable.
We all know surgery's tough, physically demanding. But for someone, say, 75 or older that worry about how they'll recover, but all the risks involved, it just feels amplified significantly.
It really is. There's that very real concern about their physiological reserve. How is their body actually going to cope with the huge stress of an operation and then bouncing back afterwards?
Exactly. And often you're just so focused on the surgery itself, right? Just hoping they get through that part okay. But what if a key part of getting a better outcome wasn't just the procedure, but really how you prepare for it and how you support the whole recovery process?
Well, that's getting right to it.
Like, what if there was actually a way to significantly cut the risk of the worst outcomes?
And that's precisely what makes the research we're digging into today so compelling and actually really hopeful. We're looking at a study. It was published in JAMA Network Open from researchers over at Memorial Sloan Kettering Cancer Center.
Right, MSKCC. So let's unpack this source. Our mission for this deep dive is basically to understand what they found about this specific approach. They call it geriatric management.
That's the term, yeah.
And figure out what it could actually mean for older adults who are facing cancer surgery. Maybe, for you listening or someone you care about.
So, okay, geriatric management. At its core, it's about adding specialists in aging geriatricians and making them a central part of the surgical care team.
Okay, that makes sense because, well, older adults aren't just scaled-up versions of younger patients, are they?
Not at all.
Their bodies handle things differently. Medications, anesthesia. They're often more prone to things like confusion afterwards, delirium. Bones might be more fragile. Nutrition's a big factor.
All of that. And recovery from a huge stressor, like a major operation, it just needs a different kind of tailored support. So the geriatrician, they're the expert, trained specifically to understand and, navigate all those complexities. They don't just see the cancer or the operation in isolation.
They see the whole person.
Exactly, the whole person. Their thinking, their nutrition, how well they move, all the medications they might be on, their support system at home, all of it.
And it's a team thing, you said, before and after.
Yeah. Very much team-based, applied both before the surgery, trying to get the patient in the best possible shape, and then critically after the surgery to really support that recovery phase.
Okay, so the million-dollar question for this study then was, does adding this specialized sort of holistic expertise into the mix actually change the outcome? Like life or death outcomes for these older cancer patients?
That was the core question. To find out, the researchers did what's called a retrospective cohort study. So they looked back at patient records.
Okay.
They examined data from nearly 1,900 patients. All of them were 75 or older, and all had cancer-related surgery at Memorial Sloan Kettering between 2015 and 2018.
Wow, that's a lot of patients. And how did they compare them?
Well, they effectively had two groups based on the care they got. One group, the larger one, just over 1,000 patients, received this geriatric management we're talking about.
Right.
And the other group, about 870 patients, they received the standard surgical care managed just by the surgical team itself.
Got it. And what were they measuring? What was the key outcome?
The main thing they looked at was pretty stark. It was mortality death within 90 days after the surgery.
Okay, 3 months. And this is where it gets really interesting.
This is where it gets, frankly, quite dramatic. Now, they did statistical adjustments first.
Right, to account for differences between the groups.
Exactly. Things like, the patient's specific age, their sex, how frail they were assessed to be before surgery, the type and complexity of the operation, even how much blood was lost. They tried to level the playing field statistically.
Okay, good. So after adjusting for all that, what did they find?
So for the group that got care only from the surgical service, the adjusted probability of dying within those 90 days was 8.9%.
Okay, nearly 9%, which sounds high.
It reflects the risks for this population undergoing major surgery. But then you look at the group that had the geriatric management, that number dropped. It plummeted really to just 4.3%.
Wow, wait, from 8.9 down to 4.3?
That's right. A reduction of 4.6 percentage points. After adjustment, it essentially means they cut the risk of death within 90 days almost in half for the patients who got that specialized geriatric support.
That's huge. That's a massive difference.
It is. They even calculated something called the number needed to treat.
What's that tell us?
It was 22, which suggests, based on this study, that for every 22 older cancer patients who received this management approach, One death within that 90-day window might have been prevented.
Just think about that. For every 22 people, one life potentially saved in those crucial first months. That feels incredibly powerful for surgery in this age group.
It really does. And what's especially fascinating is trying to figure out how. How did this approach make such a big difference in survival?
Yeah, what was the mechanism?
Particularly because the study found that the rates of immediate post-surgical problems, big complications, trips back to the ER, getting readmitted to the hospital within 30 days, those rates were actually pretty similar between the two groups.
Wait, hold on. So the geriatric team wasn't necessarily stopping the immediate surgical complication rate from happening?
Apparently not significantly, no.
But they were stopping people from dying in the weeks and months after.
Yeah.
How does that work?
Yeah.
That seems a bit backwards.
Well, that's the really key insight, isn't it? It seems to point away from just the technical success of the operation itself,
Right.
and more towards the absolute critical importance of the recovery process,
Right.
especially for older adults.
Okay.
And the study gave us a big clue. It highlighted what did differ significantly between the groups.
Which was?
Patients in that geriatric management group, they received substantially more inpatient supportive care services.
Supportive care? Like, what kind of things?
Things like physical therapy. 80% of the managed group got PT compared to only 63% in the surgery-only group.
Big difference.
Yeah. Occupational therapy, too, much higher, 37% versus 25%. And they also saw more frequent use of speech and swallow rehab and critically nutritional support services.
Ah, okay. So it's not just about, fixing the thing that needed surgery.
Yeah.
It's having that geriatric expert involved who maybe through their specialized assessment, they're spotting the vulnerabilities.
That seems to be it.
Like the underlying frailty, maybe nutritional gaps, the risk of losing function. Things a busy surgeon might not be focused on quite as much.
Precisely. And that assessment, that geriatric viewpoint, seems to trigger getting the patient the specific tailored support they need, support to rebuild their resilience, basically, to help them actually recover from that massive physiological hit that surgery represents.
So the geriatrician is kind of like the coordinator for recovery resilience.
You could put it that way. They identify who needs that extra help regaining strength, maybe preventing falls, making sure they're eating enough and the right things, managing all their complex meds to maybe prevent delirium. It seems like it's that proactive, really comprehensive support during the recovery journey that's making the life-saving difference, helping patients just withstand the stress better and, bounce back more successfully.
And this extra support, it didn't just stop when they left the hospital, did it? I think the study mentioned discharge planning.
That's right, yeah. There was a difference there, too. Patients in the management group were actually more likely to be discharged home, specifically with home supportive services already set up.
Ah, so things like home health aides or maybe therapy continuing at home.
Exactly, which really suggests a more holistic and forward-thinking discharge plan was put in place, making sure that scaffolding of support, those resources, continued even after the patient got back to their own environment, which, as you can imagine, is crucial for keeping that recovery momentum going.
Definitely. Okay, now every deep dive, we have to look at the caveats, the limitations. This was retrospective, you said.
Correct. It was a retrospective cohort study, which means they looked back at data that already existed.
So not the gold standard, which is a randomized controlled trial.
Right. In a randomized trial, patients get assigned purely by chance to one treatment or the other. Here, that didn't happen. Patients weren't randomly assigned. The decision to refer someone for geriatric management often came down to the surgeon's clinical judgment, their preference.
And it was done at just one place.
Right.
A big cancer center, but still just one place.
Yes, Memorial Sloan Kettering, which is, a world-class institution, but results might look a bit different in, say, a smaller community hospital setting. That non-random assignment also means there's a chance of selection bias.
Meaning?
Well, maybe surgeons were more likely to refer patients they already thought were sicker, or maybe the opposite, they referred patients they felt had the best chance to benefit. It's hard to know for sure. The statistical adjustments try to account for some of that.
But it's not perfect.
It's not perfect, no. It's still a limitation compared to that ideal randomized design.
Okay.
However, even with those points, you have to look at the sheer size of this study, nearly 1,900 patients, and that really dramatic, statistically significant difference in 90-day mortality. It's still extremely compelling evidence.
It really is. And the authors themselves, what was their main takeaway?
Their conclusion was pretty clear. These findings strongly suggest that, Whenever it's feasible, older patients who are facing cancer surgery should receive this kind of geriatric care management.
And this really brings it home, doesn't it? The why it matters for you part. If you or, someone you love is looking at surgery later in life, it's just vital to recognize that older adults, they really do have unique needs related to their body's reserves, how they handle stress, their whole health picture, which is often more complex.
And geriatricians are the specialists precisely trained to understand and manage all that complexity.
So bringing that specific expertise into the surgical care pathway, well, it isn't just a nice-to-have add-on. This study provides pretty powerful evidence that it can actually be life-saving.
Life-saving and significantly improve the chances of a really robust, meaningful recovery afterwards.
Yeah.
It's just a fantastic example, I think, of how collaborative care, patient-centered care that's genuinely tailored to the specific needs of a group, isn't just jargon. It actually leads to tangible, dramatic benefits, real improvements in patient outcomes.
And it really underscores that idea that innovation in medicine, well, it isn't always about a shiny new machine or the latest drug.
Not at all.
Sometimes, maybe often, it's about fundamentally rethinking how we organize care, how we deliver it, making sure the right expertise gets to the right patient at the right time.
Absolutely well said. And while the study is strong, as we noted, it also clearly points towards next steps for research.
Like those randomized trials you mentioned.
Exactly. Randomized controlled trials, maybe in different types of hospitals, would be great to confirm these findings. And maybe they could even help pinpoint exactly which parts of that whole geriatric assessment and support package are the most critical for improving survival. Is it the nutrition, the PT, the medication management, or the combination?
Fascinating stuff for the future. So, all right, wrapping up this deep dive, the core finding is pretty stunning.
It really is.
We've seen this compelling evidence from Memorial Sloan Kettering that integrating geriatric expertise, bringing those aging specialists onto the surgical team for older cancer patients, can dramatically cut mortality within 90 days after surgery.
Yeah, essentially cutting that adjusted risk in half in their large study.
And it seems to work by understanding and proactively addressing the unique vulnerabilities and needs of older adults during that crucial recovery period, often through getting them more tailored supportive care.
Right. It highlights that this support isn't just helpful, it can be genuinely life-saving and really change their whole trajectory towards recovery.
So it leaves us, and you listening, with this thought to mull over. Given this kind of powerful evidence, how do we work towards making sure that this kind of tailored expert care, care that truly recognizes the unique physiology and needs of older adults, becomes the standard? Not just a fortunate exception if you happen to be at the right hospital or get the right referral. How do we advocate for a system where their specific needs aren't just seen as, general aging, but as something requiring specialized expertise for the very best possible outcome?